Hi, thank you. Thank you very much. Thank you so much, Ruben, to have me here. I'm actually really happy that we are in the context, as also Stefan was mentioning, and Carola, of an academy. This is really important, and hopefully I will kind of convince you by the end of these 8 minutes of the relevance of this place to have a conversation on destigmatizing cannabis and bringing it back to healthcare. Do I also have a pointer here? Yeah, this one? Okay. No, it's okay. So my background is in neuropharmacology, and one of the skills that we are required to have as scientists is the ability to ponder upon what we take as postulates and wonder whether the answers that we're looking for aren't simply hidden under the sigma fog. And so one day, I was actually posed with this question, whether, I don't know if you can see it, but I think it's pretty universal, whether this was a medicine and this as well was a medicine. And until actually my third year of university, I was pretty convinced that this was a medicine and this was a drug of abuse. It was actually thanks to my pharmacology professor at the time that I finally acquired this very interesting information. So yeah, this was a new piece of information that I started to put in my brain and actually was pretty surprising. I think I am talking today with this tiny yet very lucky niche of audience that does not need any formal introduction with the endocannabinoid system. But just to summarize in one word, all of us share the production of these molecules, endocannabinoids, endogenous from Greek, what is native to our own body, cannabinoids, so molecules, actually eicosanoids, that can bind to the same molecular target that these multi-ring phenolic compounds that we all think about, like THCV and THCA and CBD and so on, that come from a plant. So the more we went on studying and understanding this physiologic system, the more we realized that the vast majority of pathologies that we were looking at also shared this balance and an unbalancing of these molecules that we produce or how we hit the targets of these receptors. So if you think about that and if you start to look at that, it totally makes sense that then we can use something exogenous, so outside from our body, like a plant, and we start to try and regulate that. Over the past 11 years, I've been involved with the scientific understanding of how we can use these molecules that activate or inhibit the endocannabinoid system in order to mainly, for myself, easing pain and neurodegenerative conditions. And what we find is not lack of evidence. What we find is rather a lack of healthcare professionals that are willing to recondition their understanding of the human body after they've been taught medicine during that 70 years of cannabis prohibition. So clearly, what is the difference between those two? Mainly is the storytelling that we have around these. So as for these, we have one single farm company, Bayer, that goes after a plant, willow, chooses one single active principle, acetylsalicylic acid, decides that that's the one they want to patent, and very quickly, fastly put it into the market. So the strong market activation made it so by the 50s, this was the most sold medicine around the world. And the best part of this is that at that time, no one even knew how this medicine was working on our body. Basically, understanding the interaction between this molecule and our biologic system has not been deemed necessary to first use this to test it on humans, but actually to sell it as a panacea. The only reason that Bayer went on to pushing new studies to actually understand the mechanism function of these was merely for commercial reasons. In the early 60s, two other drugs that I'm sure you're very familiar with, paracetamol and ibuprofen, hit the market, and they were a danger to aspirin. And so actually understanding more about it, prompted by the 1970 Dr. John Vane, the Nobel laureate, to find out that aspirin also has really good anticoagulant properties. And so this medicine remained relevant as a cardiovascular support up until today. What about cannabis? Because as we heard from Carola, it, and I would bet that pretty much any of our family doctor would stand behind this, that we consume this. But as you can tell, it's not that easy actually to find a doctor that stands behind this as a choice of therapy. So why is that? Is it perhaps because aspirin is a safer product? Okay, let's look at that. In pharmacology, we look at the therapeutic window. What's the therapeutic window? Basically, it's the difference that we have between an effective dose and the toxic, toxic, possibly even lethal dose. Now, with aspirin, you do have a lethal dose. That's around 500 micrograms per ml. And what's the effective dose? Well, between 150 and 300 microgram per ml. So what does this mean? That there is a pretty microscopic difference between what's good for you and what's going to bring you to the hospital. And what about cannabis? Okay, so we still haven't found a toxic dose so far for larger animals like ourselves, like humans. But on a theory, we should be able to consume around 21 kilograms. And I invite you to phone me up if you manage to reach that quantity. Just before actually that happens, I would like to participate. Uh, but it's a very interesting scientific studies, and we will, bring something new for sure to tell. So you see, if we compare this data, then you understand that the difference is not really about the efficacy, it's not really about the safety. Again, it's about how we activate a market, how we start doing clinical trials and actually high academic involvement onto our products. This is the main difference. And this is the main problem of pretty much, I would tell you, like 95, 98% of our healthcare professionals out there come from the concept of refer madness. What Stefan now was saying about even ChatGPT has been trained this way. So imagine your doctor coming out of med school without any knowledge about this is going to think of this, marijuana. What does your mother say when she sees your corpse? And so clearly you shouldn't, you should forgive them if they come from these and they're not really willing to prescribe or to see this as a therapy. So why it's important that we have this conversation? Because actually it's our responsibility as industry professionals really to take the hand of people and to show them, first of all, the safety of our new technology, right? And then we can start also talking, as Carola was saying, about all the crazy, sometimes over-pushed claims that theoretically this new technology can do for us. But if we skip the part in which we are providing actual information and real education outside, I believe that the, the thing that we're doing is just basically being here, like preaching to the converted is what we're doing now, right? Just preaching to the converted. But if you are hoping to get into a medical market, you're not going to be able to do it if you don't hone a really solid base of education that will propel your growth, will propel your scale. But failing to distribute education, in my honest opinion, it's actually essentially failing to even interact to a medical environment. It's just talking to a we all know about it type of environment, which is another story. It's another world, but it is not a medical market. And so just to conclude what I believe is already over 8 minutes, I wanted to share what's been our experience. So since 2017, we have been distributing courses at the University of Padua, first at the Department of Neuroscience. So that's why I was saying the importance of actually getting on board academies and research and medicine institutions. And now actually we moved it as well onto the Department of Medicine, the Department of Agriculture. And through these years of running this work and interacting with this type of institutions, we have slowly, for sure, but surely transforming what's the healthcare dimension. So just to finish up, of course, he's gonna kill me if I don't say this, but if you want me to support you as well in your country, you can scan one of those codes and see what can be of support for you. But basically, before I wanted to leave, I just wanted to say something that is pretty obvious, but I think it's important to say it back again, that when we don't know about something, we cannot use it. So as much as we see ourselves as just merely witness of this change, of the creation of the cannabis era, we effectively are authors of this change. So it is actually up to us to make cannabis going from stigma back to a healthcare. So I thank you for this.